Everyone, welcome to the Shine Connect session on early menopause. This is a session about the experience, the effects and the sort of long-term impact of going through menopause as a result of cancer treatment as a young adult. So just checking you're in the right session. Fabulous. I'm joined today by some wonderful people. I've got two more members of Shine. I'll give you a quick wave there, Ange and Ray, and we'll be telling you our stories in a bit. We've all had to consider or kind of manage early menopause in quite different ways as a result of different cancer treatments. So we'll be talking to you, telling our stories in a little bit. And we're also really lucky to be joined by Dr. Rebecca Lewis, who is a GP who specialises in early menopause. Do you want to unmute and just quickly introduce yourself, Rebecca?
Yeah, sure. Hi, everyone. Nice to virtually see you. So I'm a GP and menopause doctor and have been working solely in the menopause for the last 3 years. And it is my passion. And it's great to be here, hopefully raise awareness about the menopause, particularly in young women who have been affected by cancer treatments, and often they have very severe menopausal symptoms that go undetected for some time. So a great opportunity for me to highlight this, and I hope that will be helpful for people.
Yeah,
so thanks for inviting me.
No, thank you for coming. It's really nice to have you with us. Right, we will whiz on because we're limited on time today, but we sort of chatted amongst ourselves before the session and thought really one of the main things about being part of Shine is that we get to hear and relate to other people who've been through similar experiences as ourselves. I think often as a young adult going through cancer, the isolation can come from not coming across other people who've been through similar things. So we thought it was really important that we shared our stories with you a bit today as well. We'll talk to you a little bit about treatment and how that's meant we've had to think about menopause perhaps way earlier than we ever thought we would. So yeah, I'll introduce Ange and Ray, but Ange is going to share her story for a little bit first. Over to you, Ange.
Hi everyone. So yeah, I'm Ange. I'm the Shine Network leader for Hampshire. And I was diagnosed with breast cancer in June 2017. I had very hormonally positive cancer. So I had chemo and radiotherapy and then went into hormone therapy, which obviously put me into kind of chemical menopause state. I had a great oncologist who basically one of the first things she said when I was diagnosed, on the day I was diagnosed, was, this is going to, potentially put you into the menopause. It will affect your fertility. What are we going to do about that? What do you want? What are your plans? I was very, very lucky in that. I appreciate not everybody has that experience. But yeah, it was a bit of a shock being told at 38 when my plans were, I was about to get married, I wanted to have a baby, to be told that I was probably about to go into the menopause. I went on to Zoladex and tamoxifen, and almost immediately started having menopausal side effects. I had hot flushes. I felt like an old woman. When I got up and sat down, I felt like my joints were creaking. Yeah, very much felt like an old woman, which was, a bit of a shock. The other thing is sex became uncomfortable. I think we have to talk about that as part of this. It really affected, I think, my sense of who I was, kind of feeling old before my time. I've had a bit of a novel experience because I'm not still in that same position. I went through that chemical menopause. I took a break from my medication to see if I could conceive. Coming off the meds taught me something. It taught me that the Zoladex had made it a lot worse than the tamoxifen. As I sort of eased back off and everything kind of switched back on, I got to feel normal again. I was lucky enough to have a baby in February this year. Then after 3 months of breastfeeding, I had to go back on all the meds and go through the menopause again. But second time round, it's been a lot less difficult for me, I'd say, but I still have symptoms. Yeah, I'll pass you over to Ray. to tell you about her experiences.
Thanks, Ange. So my experience is different and quite. I've had cancer for a long time. I was diagnosed with a uterine sarcoma when I was 23, and as a result had a hysterectomy where only my uterus was removed. So I still have my ovaries. The best type of treatment for the sarcoma is surgery, because there's no evidence that chemo or radiation or hormone therapy prevents recurrence. So I went on to regular scanning just to monitor for recurrence, where then I would have surgery to have any tumors removed. So I went for 9 years with no tumors, and then I found a tumor in my abdomen. I could feel it. It was right underneath my scar. So my team at the Marsden hypothesized that it was probably some cells from the original tumor that got left behind when they removed the first tumor, and they just kind of lodged in the scar and hung out there until one day they randomly decided to grow again. So had the tumor removed, then had another 5 years cancer-free until at the end of last year on a routine MRI, we picked up another tumor. But this one was different because this one was close to my bladder. So this was a real game changer for me. For the first time, my oncologist offered me an option of having some hormone therapy, because so far all 3 tumors had been hormone receptive positive. On the potential side effects of the drugs, which actually, funnily enough, was Zoladex, which is usually used for breast cancer. And to my knowledge, they've never been used for a uterine sarcoma because it's so rare. And usually, as far as I know, I'm one of the youngest people to get this cancer. So for young women, it's just this kind of treatment has never really been done before. Anyway, so on the proposal of this treatment, my team informed me that it was highly likely that I would go into an early menopause, but that the only thing I had to really worry about was osteoporosis. But fortunately for me, I had attended Connect and Dr. Rebecca's session on menopause last year. So I was actually well informed about the menopause and that game. So that really helped me make this decision about this treatment. But I must say that apart from that, there were 2 significant outcomes for me. The first was that now that I was actually faced with an early menopause, or the potential of one, I had a lot of anxiety about how my body would change, how it might change, how I would feel about that. And one of my biggest concerns was sex, and how I would feel about it if not being a hormonally normal person at this age, would I still be attracted to my husband? Would I even want to have sex with him? And also just, it was a loss of confidence and the worrying that was quite a big deal for me. And then the second consequence was that I realized that I actually had no idea of my hormonal health. Because I had been having ultrasounds and MRIs, I could see what my ovaries were doing. The doctors could tell me, but I wasn't having periods, which was very convenient. But other than like a breakout of pimples and sore boobs every now and again, I actually had no idea what my hormones were doing. And so my ignorance really kind of hit me full on there. So that is, in a nutshell, my experience. I'll hand you back to Claire.
Yeah, thanks, guys. Gosh, we've been through some stuff, haven't we? Yeah, so my story is that I was diagnosed with a Ewing's osteosarcoma at 17, so I was quite young, and had a lot of chemo, radiation, and a stem cell transplant for that. It was kind of brutal, but I was really lucky. I went into remission at 22, 5 years later, and I haven't had a relapse with that, so that's been great, but I have had quite a lot of long-term side effects from the treatment. In terms of discussions around fertility and menopause, I remember being told that the treatment could send me into early menopause, but it was in the middle of this kind of whirlwind conversation about all the potential outcomes of my chemo. And the chemo they give you for this particular is quite aggressive, and there are a lot of potential outcomes. And to be honest, the only one I could hear at that point was that I'd got unwell enough that the chemo could kill me in itself. You know, that was the reality I was facing. And so actually, when I think about having a kind of real reasoned conversation around fertility preservation, and it just didn't happen. It was all in this kind of crazy few days of chat before I had to immediately start. So yeah, I didn't really feel I got the good chats around that stuff, but I was lucky and the treatment was successful. So that was a good thing, but it took quite some time before I really checked out what was going on with my fertility. I think I kind of stuck my head in the sand a bit, being like 20 and just wanting to be out and about and having fun. So I had some follow-up tests as my periods hadn't come back by 23, 24, and we confirmed that I had been sent into early menopause, that I didn't have any viable eggs left at all, and I needed hormone treatment. So it was kind of the worst case scenario, really. I was put on HRT, a drug called Tibolone, and side effects wise, I definitely had all the hot flushes and night sweats. And I remember finding them really irritating and embarrassing. That was another, you know, feeling like, how do I explain to people at university that I'm having hot flushes? But the main consideration, like Ray said, actually, that the doctors seemed to hold on to, because my fertility was kind of ruled out, was osteoporosis was all they talked about. So I unfortunately had to stop that hormone treatment after 5 years, because another condition I have means I'm really prone to clots in my lungs. And they were concerned the HRT was exacerbating that. So now basically I'm on treatment for my bones, but very little else. And that's where I'm at with it. I'd say probably the most difficult thing for me around the whole thing was that once I had to stop the hormone treatment, any conversations we were having around menopause, hormones, fertility particularly, just stopped, because I wasn't seeing those doctors anymore. And I think probably because I was in my mid-20s, I definitely wasn't asking the questions that I would have done when I would have been in my mid-30s, when perhaps I might have been thinking about alternatives for fertility and having children. So I think for me, the main thing that comes out of it is that without having those medical conversations, you also can fall into this trap of not having any sort of holistic conversations and getting any support about how you feel about the whole process and what it's like to know that you're infertile at 25. That's a big deal. And I think you can kind of, if you fall out of the system, you don't get those conversations anywhere. So that's definitely part of the process that I would have wanted to be different. So very neatly segueing, talking about medical conversations. See what I did there? It's clever. We're really lucky to have Dr. Rebecca here today. We're going to have some of those conversations that maybe we would have liked to have been having. And yeah, kind of like a menopause 101, if you like. So we have some questions that we're going to ask you, and hopefully we'll cover the basics and we can answer the more specific questions in the live Q&A later. But to start off, I guess it seems like a straightforward question, but I think it's one, particularly if you come in as a younger person, maybe you don't, because you're not expecting to go through the menopause, you actually don't know much about it. And perhaps a very basic question like, what is the menopause? We don't ask those, and some of us can remain ignorant for some time. So, Rebecca, what is the menopause?
Yes, well, it is a good question, really. I mean, it comes from the Greek meno, month, pause, to stop. It's defined as 1 year and 1 day after your last natural period. Okay, it's important to know that the average age in the UK is 51, but 1 in 100 women naturally will go through the menopause under 40. So it's not a disease or a problem in women in their 40s and 50s. You know, 1 in 100 is not unusual, will be under 40 naturally anyway. We're seeing many more younger people going through the menopause because they have had cancer treatments. And the problem is with cancer treatments is the chemotherapy, not all chemotherapy, but quite a lot of the chemotherapy will damage the ovary and irreversibly, and stop it working. So the menopause really is all about your ovary working properly and then stopping working. We're born with millions of eggs, okay, and every time we ovulate, they just run out. We lose them, if you like, every year that goes by. So what can happen with the chemotherapy or surgery or radiation? All these things are toxic to the ovary and and destroy the tissue there, and destroying the eggs inside for fertility. And therefore, if the tissue is destroyed and the eggs are destroyed, the main function of the ovary is to produce the eggs and to produce hormones with that, which the main hormones are estrogen and progesterone, and importantly, testosterone, which a lot of women aren't aware of. These three hormones are really vital for female function. Underlines so many bodily systems, the presence of estrogen. And when we lose estrogen, we then get symptoms of estrogen deficiency, much the same as if someone had a thyroid problem and hypothyroidism, and they're given thyroxine back. This is the same sort of situation. The ovary has been damaged and stops working, and therefore stops producing eggs, and these hormones, estrogen being the main one. So that's what it is.
Gosh, so much I didn't know already. So let's talk. I think a thing we get asked a lot about is symptom management and what to expect. And I think also going through treatment for cancer, you're also undergoing, like, you've got so many drugs in your system and some long-term effects. You have all these new symptoms. And it's really hard to distinguish what's what.
This is absolutely right, Claire. Absolutely right. It's such a difficult time, obviously, for anybody having the diagnosis, going through very challenging treatments. And of course, the focus is all on getting the best treatment for yourself and getting through this, and quite rightly so. And it can be difficult to discuss perhaps as deeply as it should be discussed before, as some cases are emergency cases, like you perhaps, Claire. But it's really important that it is discussed. And in fact, I work at Newson Health. Dr. Louise Newson is a real pioneer at sort of helping women understand the menopause and getting rid of the taboo about menopause. And that covers every woman. It's not necessarily people who've been through the cancer treatments. And we've written a leaflet for women who are going to undergo cancer treatment. So to be distributed, we hope, in the NHS, to start the conversations going early about what is going to happen to their ovaries and the results of not having hormones. So what are the symptoms? Well, as I said, estrogen gets everywhere. Really important in the brain, okay? There's an area called the limbic system in the brain, and that's to do with our memory, our concentration, fatigue, libido, mood, anxiety levels. And this area of the brain, it's on the side of the brain, estrogen is a vital neurotransmitter. Okay, so it's, if you don't have estrogen, what can happen is we get more anxious, our mood lowers, get really flat and low, no energy, loss of joy in life, the excitement, even when you're feeling better from the cancer treatments, the energy isn't there, the interest in things, can't be bothered, feeling like you're dragging your body around the house. It's very, very, it can be very profound, some of those symptoms in some women. Libido, just not on the radar, not even thinking about the sexual sort of part of yourself at all. So really, really very powerful symptoms for not everyone, but many women. I mean, 80% of people will have symptoms and 25% will be severe. So, some poor women really are almost suicidal without estrogen. Not everybody, but that can be that profound. So yes, the quality of life, as you can imagine, if you have serious symptoms like that, can be very severely affected. And of course, these sort of symptoms, just sticking with the brain for the moment, can often be confused with other things. Oh, well, of course I'm feeling low. Of course I'm feeling anxious. Look what I've just been through, for God's sake, of course. And people will all say that, of course, well, you will feel depressed, have an antidepressant, you've just been through this, and more anxious about recurrence or, what's going to happen in the future. And so it gets pushed to the side. It's not to say you can't have both things, but it's actually really important to know how estrogen affects you, so that you could do something about it if you choose to do that. Brain fog. is really profound. We can't get the right words quite often. You know, we're stuck in the middle of a sentence just for simple words and not coming to the front. You know, it's the keys in the freezer, you know, and glasses somewhere else. You know, everything is an effort. We forget things. And of course, this can often be put down to chemo brain. And it's not, it's actually due to lack of estrogen. So that's the brain symptoms. The hypothalamus is our thermostat, and everyone knows this. You know, hot flushes and night sweats occur because our thermostat is not functioning properly without estrogen. Now, some women, 20% of women don't get hot flushes and night sweats, actually. So if you're having all the other symptoms but no flushes and sweats, you might think, aha, I don't have any menopausal symptoms. That's incorrect. 20% can have every symptom, and they're about 30 or 40, but no flushes and sweats, and not realise that actually they are menopausal. In the heart, palpitations are very common. Muscles and joints, that's a big one. Really stiff, achy muscles and joints. So ligament pain. Hands can be very, very almost like claw-like in the morning. They can be so stiff, or if you've been going for a walk with the dog and holding the lead, you know, it's difficult to release your hands, because the joints are so stiff. Turning over at night, you ache because it's stiff and painful. And of course, if you've had, you know, bone cancer or something, that's a worry that you think there's something coming back. Of course, that always needs to be checked out. But it's usually a general aching, perhaps coming down with flu, or I've been too long at the computer, it's aching all the time, and it can make you feel very old and aged. You know, stiff, can't touch your toes, can't get that. You know, almost if you're sitting in a chair watching a film, if you just take the chair away, you feel like you'd stay in that sitting position like a cartoon character. It can be that profound. So joint pains, irritable bowel is much more common, bloating, nausea, discomfort around there. And one of the really important things is vagina and bladder symptoms. The vaginal walls get much thinner and drier. You lose that layer of lubrication in the vagina, and that becomes dryness. Can often be the wrong word to describe it. For some women, not all, for some women, it can be really painful, burning. So let alone sex, cannot sit down, cannot wear jeans or underwear, is rubs, and it's a burning pain. It's like poker, you know, hot red poker sort of feeling. So of course, libido, you know, which is already affected in the brain, and then if you do have sex, it's really uncomfortable. You know, no one will want to have sex. It can be very, very uncomfortable. Thrush and BV can happen much more as well, because pH changes, because we lose that layer of lubrication, which keeps the bacteria under control in the vagina. The back of the bladder shares the same wall as the vagina. It's very near it. So if we lose that layer of lubrication, bugs, which we have bugs in our skin and in the vagina, it's healthy to have that in certain areas. But if the bug goes into the bladder, it's not healthy, and we can get a urine infection. The pelvic floor is affected by the lack of estrogen, so it gets weaker. And the bladder muscles don't function without estrogen. So keep wanting to go to the loo, getting up and going for a wee every night, or, you know, having accidents, even cough or a sneeze, you can leak urine, or urgency, oh my god, I've got to go now, quick, and you can leak as well. So these, and dry skin, dry hair, dry eyes, you know, really quite painful. The eyes can be very, very dry, sore, dry mouth. Tinnitus is very common, ringing in the ears, and nerve dysfunction. So a lot of people get pins and needles and burning type. It comes and goes through their hands and their feet. So you can see a heck of a lot of symptoms.
There's so many more than I'd even appreciated. And
yeah.
I was just wondering whether, I mean, is there evidence, or do you know if people who go through this younger, or through chemically, or after surgery, are those symptoms worse or better, or last longer or shorter? What's the effect?
So we need more research in general about the menopause, and is there a difference in younger women than older women, say, who go through it naturally at say 51? But generally, no. It could be a much harsher menopause though for people who've had their ovaries suddenly removed by surgery or by irradiation or chemotherapy. So you go along with normal estrogen, bang, suddenly no estrogen, with drugs and things like that. So it could be a real hard menopause that can affect you very, very profoundly, very quickly. So I think younger women suffer quite a lot because of that, with all those symptoms, but a grade or two worse quite often. Sometimes they don't have flushes and sweats, perhaps less commonly in the younger age group, but that's not proven. But the vital thing is, for young women, it's really important to have their estrogen, because not only all these horrendous symptoms I've just described, and by the way, not everyone has them as badly as that, but I think it's good to know that there is a variation. So just because you're not having a problem, your friend can have a problem. And just because you don't have drenching sweats at night, your friend can. They have to get up and change the sheets sort of a couple of times if they could every night. It could be that profound. So not only the quality of life goes down without estrogen, with all these symptoms, the long-term health effects without estrogen are particularly significant and important for women under the age of 45. Without estrogen, there is an increased risk of osteoporosis, heart disease, dementia, type 2 diabetes. So it affects our long-term health, and we need to think about that, because one of the treatments is hormone replacement therapy, and many cancers can have hormone replacement therapy. Some of the estrogen sensitive cancers are not able to, but if we think about all those domains that estrogen is important in, we need to look not just at the bones for osteoporosis, we need to think about our heart. What is our exercise like? What is our diet like? The brain activity, maximizing now to help prevent these diseases that we're at increased risk of without estrogen. So that's really the important message I want to get out, how important estrogen is for all of us.
Yeah, absolutely. And I think it can be quite kind of intimidating to hear all of those things if we're just coming into this journey. And so I think it's really important we talk about the fact that there is solutions and things we can do to help. And
there are solutions.
And also, I was just going to quickly say that the three of us, it's obvious that people's experiences are very different. And so let's talk about some of the solutions and how we personalize them to make them work for the individual, rather than going down a one size fits all approach, because we know that's
and menopause treatment should always be individualized, no matter what your history, cancer or no cancer. But certainly with people who are cancer survivors, they need to have an individualized approach, and may need to see a doctor with an interest in menopause, to help sort of find the right solution for them. So one of the first solutions is hormone replacement. And I will say that first, because it is the most effective treatment, because the solution is lack of estrogen, and replacing that estrogen obviously will get all around the body, and with one treatment could solve all the problems, if you see what I mean, because it's replacing like with like. So like a thyroid deficiency, you'd give back thyroxine to get the body back to its normal modus operandi, if you like. And there's a lot of there's so much taboo and myths about HRT that we need to say a few things. For example, blood clot. I think you mentioned, Claire. There's no increased risk of blood clots with transdermal HRT. So estrogen through the skin does not increase your risk of blood clot. In our clinic, what is commonly used now, the best type of HRT is transdermal HRT, which means through the skin, estrogen gel or patch. And then if a woman has a womb, they have to have progesterone as well, and that's called combined HRT. For young women with HRT, there is no increased risk of breast cancer with HRT, a de novo breast cancer. I'm talking people who haven't got hormone sensitive cancers. So for other cancers elsewhere, then that would be a safe option for women to have. There's no time limit for having HRT as well. We would say a young woman in their 30s ideally should have hormones at least to 51, and then we don't count how many years they're on HRT if they choose to continue, because they're just replacing the hormones they should have had, if you like. So if you're 45 and have been taking HRT for 10 years, that doesn't count. 10 years would be when you're 61, 10 years after 51, if you see what I mean. So there's no time limit for taking HRT. So what we don't want to see is people who have had bone cancer and they're on HRT and, from the age of 30 to 35, and they're told stop because they've had 5 years. That's nonsense. That needs to carry on to 51, if there's no problem having HRT. So that's the number one, the safest, the most effective treatment for menopause. There are other treatments. Remember how we said it affects different parts of the body. So if women who've had a hormone sensitive cancer, things like antidepressants, not for the mood, but for the flushes and sweats, have been shown to help the flushes and sweats. So that's an option. And there's several types, and SSRIs, pregabalin. CBT is actually proven to be helpful for flushes and sweats and anxiety management. Osteoporosis, HRT will treat osteoporosis and help prevent it. But if you can't have HRT, you choose not to have HRT, then there are other medications specifically for osteoporosis. Of course, we must think about weight-bearing exercise. All of us should think about weight-bearing exercise regularly through the week. We should try and have 2.5 hours moderate exercise a week for our hearts, to help the heart. Healthy diet, looking at the cholesterol intake, and pay attention to that. Pay attention to the weight, which can be difficult to lose if we are in the menopause. All these sort of things for our cardiac health, for our bone health, and for our mental health as well. So there are other things to do from that. So diet, relaxation techniques, CBT, and medications specifically for flushes and sweats. Migraines are quite common as well in the menopause, and HRT will help that. But if you choose not to have HRT, there are other medications to have for those sort of things. So that's really how you would approach it in a general way. But of course, it's all individualized to the person, and they go through what's happened to them, and then of course it's their choice what they want to do.
Yeah, it's a big relief to hear that there are lots of things we can do about all these symptoms, which, they do sound quite overwhelming, don't they?
Yeah.
We could talk about this for hours, I'm sure, but unfortunately we're time limited. So what we'll do is we'll wrap up this part of the session. Thank you all guys for sharing everything. And we're all really excited to come and join you in real time in the live Q&A, in which we might be in different rooms wearing different clothes, but it'll be seamless. And we'll see you there in a moment. Thank you so much, guys.
Thank you.